Let me give you a perspective of the Cleveland Clinic ICU and as to why the project was initiated. So we are a 68-bedded medical ICU, and we take care of just under 5,000 patients in any given year. It's one of the biggest ICUs in the country. Blood is an expensive resource. It's a limited resource. It's tough to procure. It's tough to treat. And having said that, what I intended to do was to look at as to how well we are adhering to our guidelines. It was a very simple observational study. We have guidelines, and how well are we doing? And so what we did was we evaluated over 3,000 plus transfusions in the medical ICU, just under 1,000 patients. And we're happy to report that in just about 10% of these cases, where did we deviate from published guidelines. That was reassuring for my institute and for my ICU. Our ICU is a very sick ICU. It's a quaternary care center. A third of our patients are mechanically ventilated. A third of our patients are in septic shock. More than a third have underlying liver disease or are immunosuppressed. Our mean Apache score and marker of severity is 85 for these patients who got transfused. And overall in the medical ICU, it had averages for that year that we did was 65. So it is a very sick ICU. And despite those pressures, the fact that we kept these transfusions, what one would say unwarranted transfusions, to less than 10% was a pleasant surprise. What we wanted to do was what we think we'll do in the years to come is what we'll do in the months to come would be to look into those compulsions that guided these transfusions, these unnecessary transfusions. I think I have an idea. We used a hard target hemoglobin value of less than 7 as our cutoff point. But would you fault the intensivist or the doctor for transfusing the patient a unit of blood when the value is 7.1, knowing fully well that it's going to drift down in the days to come? So there were a bunch of transfusions that happened in and around the 7.1, 7.2. There were transfusions that also happened with values above 8, and that usually was happening for patients who had underlying malignancies or who were bone marrow transplant patients. We still have a work cut out for us, but on the whole, I'm reasonably pleased with the results that we have. We showed a mortality difference in patients who were transfused above the threshold of 7, and if it was unwarranted, we noticed a higher mortality in those patients. But I think if we were to take a closer look at these patients, divide them into distinct groups: patients who had chronic blood loss anemia, patients who had acute blood loss anemia, patients who had both, indication for both acute and chronic, maybe the signal will differ. We don't know that yet, and we are trying hard to go back into the statistics and figure that out.